Dr. Ken Lando. Thanks for watching. Let's talk about iron deficiency and iron deficiency anemia. Common condition, 4 to 8% of premenopausal women suffer from a deficient level of iron. It's rarely due just to the diet alone. It's rare in men and postmenopausal women unless there's a history of some sort of bleeding disorder. On the other hand, in different countries, Nepal, Sudan, 2/3 of children and adolescents will be iron deficient. Now, the symptoms of iron deficiency are non-specific. As a matter of fact, you can have significant iron deficiency and have no specific symptoms, no symptoms whatsoever. But some people are tired or short of breath. They have leg cramps when they're climbing stairs. They have muscle twitches. They're weak. They can't physically function as well as normal. They have poor scholastic performance, maybe cold hands or cold feet, intolerance to the cold. Maybe they have pale skin or chest pain from maybe an increased heart rate. Their nails can be brittle and spoon-shaped. They can lose significant quantities of hair. For some reason, they develop a peculiar craving for non-nutritive substances. For instance, they eat ice or dirt or starch or clay. The restless leg syndrome may be a symptom. And there's decreased resistance to infection. Some people develop a whooshing or a pounding sensation in the ears, or headache or dizziness or lightheadedness, or depression, where the blood pressure can fall on rising from a seated or lying position. And sometimes the tongue becomes smooth or inflamed. Children and infants can suffer a decrease in IQ, slow learning, and there are pregnancy-related problems. Problems associated with premature labor, delivery of a child, low birth weight. Iron deficiency tends not to go on to cause death, but may be very important as far as worsening heart disease or worsening lung disease. Now, iron is important because it carries the oxygen in the form of hemoglobin complexes to the various tissues. It's also used to transport electrons within the cells, and it facilitates the oxidative enzyme reactions in various tissues. Those most susceptible to iron deficiency, well, children and premenopausal women and people who have a very poor diet. The cause tends to be from blood loss. Well, blood loss could be you donate too much blood, maybe significant menstrual losses or gastrointestinal bleeding, bleeding that you don't recognize. Small amounts of bleeding that may be associated with taking aspirin, or ulcers, or having hemorrhoids, or unfortunately either stomach or colon cancer. Some people develop polyps that just bleed a little bit, but that over a period of time adds up, or it may be more massive. People with ulcerative colitis, damaged heart valves, or maybe you lose the blood in the urine. Some people have inadequate intake, especially the vegans. They have about a 6 to 8-fold increase in the iron deficiency risk. Vegetarians and older people who are less fortunate can't spend too much money on food, and they follow what's been referred to as the tea and toast diet. Pregnancy and breastfeeding causes a significant depletion of iron from the woman, the mother. And we also have a problem where achlorhydria, lack of acid in the stomach, maybe a lack of acid because you're taking medicines for gastroesophageal reflux disease, and it combats the acid, or maybe you're taking some of those pills. Well, that can cause a problem with the ability to absorb iron. And in the inner city, lead exposure decreases iron absorption, as do problems with endotoxin, a consequence of infectious diseases, or inflammation. Inflammation like inflammatory bowel disease, rheumatoid arthritis can decrease the iron that's going to be in the system. And so too can a variety of medical disorders that sequester the iron and make the iron not available for manufacturing blood. Congestive heart failure, renal transplant, chronic infections, sickle cell disease. And interestingly enough, athletes can become iron deficient. Athletes, because of mechanical hemolysis, when the foot strikes the ground, it can actually break up some of the red blood cells. That's the high impact sports like long distance runners. We call it foot strike hemolysis. And you can lose blood in the urine, especially in the military, marching, prolonged marches. And even people who are Congo drummers, who are constantly banging their hands on the drum, that can cause significant disruption of the blood cells. And then, of course, we have people who are excessively concerned about their weight, ballerinas and gymnasts. They can become iron deficient. So if we look overall, it seems like iron deficiency is caused frequently by duodenal ulcers, stomach ulcers, and aspirin, and colorectal cancer, and blood donation, and even celiac disease can cause a problem. If we look at infants and children, they have a tendency to develop iron deficiency, especially if they're low birth weight or preemies, or they're not breastfed, or as children they become vegetarians, or they consume too much milk. It's thought that more than 16 ounces of milk is too much because you get the calories, but milk has relatively little iron in it. Well, how do we make the diagnosis? The diagnosis of iron deficiency anemia is, well, the person's anemic. So we do that on a simple blood test. But not only is the person anemic, the red blood cells themselves tend to be relatively small. They tend to be relatively small. They don't have to be relatively small, and you don't have to develop an anemia. But those are obviously major factors. The blood cells themselves not only are smaller, but they also tend to be relatively pale, and the platelet count can be increased. We look at the hematocrit, and the hematocrit that would normally be in a woman between 35 and 45 might now be lower. Or the hemoglobin in a normal woman, anywhere between about 12 and 15 and a half, can be lower. We can also test other things. The storage form is associated with ferritin, so we can measure the ferritin, but the ferritin can go up even if you're iron deficiency if you have an inflammatory disease. For instance, if you have inflammatory bowel disease, or if you have a chronic disease like congestive heart failure, it can go up. So we measure another test, the C-reactive protein, to check to see if there's inflammation. Or we can measure the iron in the system, or we can measure the iron saturation in the system. And then we go on and we can test for occult blood in the stool. We do one of those stool blood tests. But that can be positive only if there's more than 20 milliliters of blood lost every day. That's a fairly significant amount of blood. If you lose less than that amount, the fecal occult blood test frequently does not pick it up. On the other hand, you can become severely anemic with just small amounts of gastrointestinal blood loss. So then we look in the upper part of the intestinal system. We put the tube down and look at the esophagus, look at the stomach and the first part of the intestine, or we can do the colonoscopy. We check the urine to see if there's any blood. And then we check for the chronic diseases that a person might have, maybe lead poisoning. Well, it's possible that you can have iron deficiency, but you haven't yet progressed to the form where it affects the ability of the red cells to manufacture the hemoglobin. But if the deficiency continues, you ultimately probably are going to develop iron deficiency anemia. That's the most common nutritional deficiency in the United States. It's not generally present in men. It's not generally present in postmenopausal women. Remember, unless there's a bleeding disorder. Should we screen? Well, it's been said that we should screen children at 1 year of age, and we should screen women during pregnancy. There are different levels of the hemoglobin in the first trimester and the second trimester. But the United States Preventive Services Task Force said, actually, we probably don't need to routinely screen women, and we probably don't need to routinely even supplement women. They say you might not even have to check children, unless, of course, that there's a story about low birth weight or prematurity, or the children are malnourished. Well, 2/3 of the iron that's going to be in the system circulates in the bloodstream in the form of hemoglobin. It's inside the red blood cells. So 1 milliliter of blood contains about 0.5 milligram of iron. During a normal pregnancy, that means that a woman is going to lose about 500 milligrams of iron. And during a normal period, anywhere between 4 and 100 milligrams of iron. During the course of a day, a normal individual, every single day, you're going to lose about 1 milligram of iron. And it's going to slough from the cells, the intestinal cells, and the skin cells, and through secretions from the gut. But we're going to replace that. We're going to replace that 1 milligram. how much iron does a typical woman consume? During a typical day, a woman's going to consume about 13 milligrams and a man's going to consume about 18 milligrams of iron. It's estimated at the present time that somewhere around 1 woman in 6 is not going to meet the RDA, the recommended dietary allowance, and about 3% of men not going to meet that particular allowance. Now, we have different allowances for different age groups. So if you're 14 to 18 years of age, you need about 10 milligrams of iron every day. On the other hand, between about age 20 and 50, for men, it's only about 8 milligrams because we're not growing as much during those years. And women, on the other hand, during those same years, because of the menstrual blood loss, the RDA is estimated at 18 milligrams, but it falls back to the 8 milligrams as it is in men after the women go through the menopause. Now, if a woman is pregnant, the woman's going to need about 27 milligrams of iron a day and need just a smidgen more than normal, just about 9 milligrams during the time when she's lactating. Now, the way you get your iron is through your diet, of course, but most of the iron in the system is going to be reused. It's in red blood cells, circulating red blood cells. That's the overwhelming majority of the iron that you have. And the blood cells are going to die every 120 days. So that's the lifespan of a red blood cells, which means that about 1% of the blood cells are going to deteriorate every single day. And that iron is going to be reused. So we're going to have to only absorb about 1 milligram of new iron every single day. We're going to consume, typical man, about 10 to 20 milligrams every day. A woman needs to absorb a little bit more, about 2 milligrams a day, because the woman's going to eat less and she's going to have those increased losses. Now, if we look at newborns, they contain about 250 milligrams of iron. 450 milligrams is a pound, by the way. So about half a pound of iron in a child. On the other hand, if we look at an adult male, well, they contain somewhere less than 4,000 milligrams of iron. And a woman, an adult woman, contains about 2,000 to 3,000 milligrams of iron. So remember, we need to absorb 1 milligram because on an average you're going to lose 1 milligram a day. But the internal requirements of the body for iron are about 20 to 25 milligrams a day. And most of that iron is going to be met through the reuse of the iron in the hemoglobin that's going to break down when those red blood cells die. There's some other iron that's going to be used from the muscle cells and from some of the enzymes in the system. Overall, the iron is going to be principally absorbed from the first part of the small intestine, the duodenum, and then a little bit from the second part, which is called the jejunum. There are different mechanisms to absorb different kind of iron. So, for instance, we have the iron in meat. We call that the heme iron. That's easy to get into the system. Much more difficult is the iron you get in from the supplements or from the food sources or from the grain. That's either the ferrous or the ferric iron. About 1/3 of the iron that we consume is called heme iron. Heme iron gets into the intestinal lining cell and passes right on through it. That's relatively easy. On the other hand, the mechanisms for absorption of ferric iron, that's oxidized iron, or ferrous iron, that's reduced iron, that's the kind you get as a supplement, that's much more difficult, and it's impacted by a significant variety of foods. Now, it seems that those intestinal cells act as a gatekeeper. They act as a gatekeeper, and they get their information on how much iron to let in by how much iron goes from the bloodstream into the cell and other chemicals that impact on the intestinal cells. So they regulate it quite significantly. In the plasma, the iron floats around bound to a chemical known as transferrin, and in the storage form, it's ferritin. It's bound to ferritin. Now, interestingly, even though we talk about iron deficiency, you can get too much iron. Too much iron is a condition called hemosiderosis, and a disease related to that is hemochromatosis. Hemochromatosis, when we store too much iron, that is a significant problem and may lead to coronary artery disease and diabetes and stroke and cancer. And it seems that about 8% of the population contains one gene, 8% of the population with one gene that would allow an increase in the iron to be absorbed and stored inside the body, which is a problem because in 1946 the government decided that there should be fortification of foods with iron. We should enrich our grains. And about half of the iron in the U.S. food supply is going to occur because of the supplements that are added to cereals and added to grains. Well, it's important that we don't have too much free iron floating around because the bacteria that might otherwise cause infection need iron. So we want the iron to be bound. We don't want it to be too readily available. So not only do we have the chemicals that we talked about, the transferrin and the ferritin, but also, for instance, in breast milk, there is a significant amount of lactoferrin. It binds the iron. That's why children who are breastfed are less likely to develop other kind of infections than children who are fed formula. Lactoferrin is also present in tears and saliva and wounds. So what do we do once we've established the diagnosis of iron deficiency anemia? Well, we look for the cause. And the cause, especially in older people, happens to be through GI loss, gastrointestinal loss. 60% of adults with iron deficiency have some sort of gastrointestinal disorder. Well, we also want to have an appropriate diet. We want to get the iron in. And the iron goes in best as meats and somewhat less so as eggs or green leafy vegetables or iron-fortified foods. If there's heavy menstrual loss, there's always the birth control pill. If a person has a peptic ulcer, well, certainly we treat that, and surgery might be necessary for polyps or cancers or fibroids. There's the suggestion that after delivery, we can allow the newborn to get extra iron sources if we don't clamp the cord for about 2 minutes. That seems to work for a certain period of time. Now, the best way to get iron into the system is with red meat or seafood or poultry. Best absorption, easiest absorption, not interfered with by other kind of dietary substances. On the other hand, if we have the non-heme iron, maybe the lentils or the beans or the leafy vegetables or the spinach or the peas or dried fruit or tofu or the fortified breads and cereals and rice, well, those inorganic forms of iron are best absorbed if we have some vitamin C around. So it's a good idea to consume with them some citrus or some broccoli or leafy vegetables, tomatoes or strawberry, kiwi, or even take 250, 500 milligrams of vitamin C. On the other hand, we have some foods, especially spinach and chard, that contain substances like the oxalates and phytic acid and the phosphates and the carbonates that actually are going to inhibit the iron absorption from other foods that you might eat at the same time. You could take an iron supplement, but the iron supplements can upset the stomach and they might lead to constipation or diarrhea. They're certainly going to turn the stool black. You shouldn't take them with antacids. And remember that tea and coffee contain some of those substances that are going to decrease the absorption of iron, so you have to be careful with them. It's going to take a fairly long time to get iron levels back to normal. It takes months to correct an iron deficiency. It might even take a year or more. Typically, we take an iron supplement, ferrous sulfate, a 325 milligram tablet of ferrous sulfate contains 65 milligrams of elemental iron. We used to say take it 3 times a day. But actually, the larger doses seem to increase certain substances that tell the intestinal cells, hey, stop absorbing this stuff. So that might actually be a problem. Maybe a smaller dose, a considerably smaller dose, maybe taking it every other day. And remember, take it with some supplements of vitamin C, maybe 250, 500 milligrams. Maybe that will be sufficient in order to get the iron into the system. So a lower dose, taken with vitamin C, maybe taken every other day, may well be more helpful in getting iron through the barrier of the enterocyte, the intestinal cell. And if we can't get the iron in, then it could be given either as a transfusion in rare instances or intravenously. But The importance is that iron and iron deficiency is still pretty common. And there are certain people who seem to be at greatest risk: the children, menstruating women, women with a history of heavy periods or delivery of children. We know that those people seem to be at increased risk. And children who were born at low birth weight or premature, those individuals seem to be at greatest risk. And remember, iron has an awful lot of functions inside the body. It's a critical substance, not only for hemoglobin, for a variety of other important chemical reactions inside the body. So now you know all about iron. Thanks for watching. I'm Dr. Ken Landau.